speaker is Chris Ockenhouse. He's the Director of Medical and Clinical Operations at Path MBI, and he'll talk to us about regulatory approaches that might be taken for accelerating a TBB. Well, thanks, Chris.
Good morning. It's a pleasure for me to be here. I'm going to recapitulate some of the comments and the from Andrew, Toon, and James. Now, we're going to talk a little bit about what does it look like, what does success look like for a transmission blocking vaccine, and how can we either test and get some type of regulatory approval. So I think we ought to start with the basic premise from the Malaria Roadmap 2013, presented last year at ASTMH. There's an unmet medical need. And transmission blocking vaccine, we at MBI think is an essential and important component of a vaccine for elimination in conjunction with other malaria elimination tools. I think one of the premises that we need to start is that the activity of the transmission blocking vaccine from that it's blocking the transmission of parasites from mosquitoes to man, and the biological function of such a vaccine is measured in the mosquito and not in humans, unlike a lot of other vaccines. It's important to realize that the vaccine efficacy is measured at the community level and not the individual person per se. And this is important as we consider how we measure efficacy and how we get it regulated and licensed and registered. The benefit, as individuals previously pointed out, to an individual is indirect because it's through protection at the community. It's delayed, that won't occur immediate after vaccination. And it's determined by a set of factors that are independent of the immunogenicity. And this becomes a problem. What is your vaccine coverage in your population? What is the transmission intensity that you plan to introduce your TBV into? Population movement in and out of an area of individuals who are not vaccinated. And what about vectorial capacity? These are all factors that we have to consider and are actually very important and difficult ones to overcome. Now, as we consider clinical pathway, we also want to minimize risk. These studies are not inexpensive, and so we would like to manage two types of risks, those associated with false negative results and those associated with false positive, and I'll mention those briefly. So if we start with a strict regulatory agency, such as the FDA, what is their stated position? So in 2010, at a MBI transmission blocking workshop, FDA said that approval could be based on indirect benefit alone, but would be made in the context of a license application. That opens up the possibility that you don't necessarily need to provide a direct, immediate benefit to an individual, but the FDA would consider indirect benefit based on a population. And there's no clear legal barrier to licensing a vaccine with no direct benefit. And importantly enough, I think most of us don't realize that regulatory agencies, including the FDA, do encourage frequent consultation. I think they encourage that. In fact, MBI met just last week with the FDA to discuss these ideas of transmission blocking vaccines. And so frequent dialogue, I think, is not only encouraged but welcomed. So as we consider paths to registration, for a lot of people in this room, it's probably somewhat boring, but it's really important because we have to consider, we've thought of two paths. There's a conventional path, clinical regulatory pathway, and I'll talk about how one would design such a study. And then there is an accelerated approval pathway in which a biomarker is an endpoint in such a trial for efficacy. And I'm going to discuss examples of a conventional pathway and accelerated pathway. So an alternative pathway is actually also included in the Code of Federal Regulations in the U.S. government, FDA. and that the FDA could grant licensure on the basis of an adequate and well-controlled clinical trial or trials establishing that the biologic product has an effect on a surrogate endpoint that is reasonably likely to predict clinical benefits. So a surrogate endpoint is a biomarker, and would such a biomarker be reasonably likely to predict clinical benefit? And the approval is also subject to a requirement that the applicant study the biological product further to verify and describe its clinical benefit. In other words, we have to show in such a confirmatory field trial that the surrogate actually predicts clinical benefit. So let me take you down two routes here. The first route is typical what you would do in any clinical trial. You would have a phase 1 and a phase 2. As you heard from the previous speakers, we would have mosquito feeds and standard membrane feeding assays or direct feeding assays. And you would have through both phase 1 and phase 2 as you optimally formulate your dose and your schedule. In the conventional pathway, there's different types of trial designs. I'll briefly describe a cluster randomized trial in a phase 3. You would go to registration, and then you would test it for effectiveness in combination with other malaria interventions. In fact, you may actually test your primary vaccine with mass drug administration, bed nets, certainly maybe IRS spraying in addition. Such a pathway is not without the issues, and I'll describe them in a bit. The alternative, as I mentioned before, accelerate it. You would need an analytically and biologically validated surrogate biomarker, perhaps a challenge study. This is where mathematical modeling can have a strong impact. Determine what is the efficacy that we need in order to lead to malaria elimination. And then epidemiologic supportive data. This is all those types of things that the FDA would want to see if we would consider an accelerated approval pathway. And then you would get it registered. But then your work doesn't end there. You have to confirm in this phase 4 that in fact the registered product does what it's intended to do. So briefly, what are we going to measure in a conventional pathway? Well, I think everybody in the audience understands that the indication for such a vaccine is prevention of incident infection. That's what we want to do to lead to malaria elimination. We're not going to measure clinical disease as an endpoint. So the goal is to demonstrate a beneficial effect of vaccination on malaria parasite transmission from the mosquito to humans. And incident malaria and parasite infection in a human population in a trial, you could measure it over 1 year, and then you would do repeated administrations, perhaps through boosting over 5 years, and determine the effectiveness of your vaccine in leading to elimination. And then you would have, obviously, secondary objectives looking at immunogenicity and mosquito infection rates and other entomologic measures. So what is a cluster randomized trial? Now this is just an example of what one would consider, and I want to show you some of the complexities. It could be as high as 56,000. Some people have suspected, depending on where you do it and the transmission intensity, up to 100,000 individuals. Depending on what your vaccine effective is, 50%. There's variation between clusters. I'll talk about a cluster. Where are you going to do it? What kind of transmission setting? If you have a transmission setting that is too intense, you run a risk of a false negative, and I'll talk about that in the next slide. And so if you think about how you would conceive of a transmission blocking vaccine in a cluster randomized trial, you think of hundreds of clusters where you have individuals in a cluster that get the vaccine, adjacent to that in a geographic location, a control group. You have a sentinel group inside that is protected, and that is what your endpoint efficacy will be measured on. And you have a gradient effect between the control and a vaccine. And this is illustrated in this figure to the right here, where it's instead of looking at a dichotomous control versus vaccine, you can take into account what goes on in the border area this is based on incidence of malaria. So in a control population, you would expect that your incidence of malaria infection over a year is going to be greater than in your vaccine population, and you can get greater power by including a gradient. And this is one of various different design methods that one could conceive of. Now, there is risk associated with conventional. I wanted to talk about a false negative. And we're extremely worried about this because we have to be able to pick the right geographic location and transmission intensity to see if the vaccine works. Because you only have one try at this. And it's not a short trial, and it's quite expensive both for the sponsor and for the funder. And so a pivotal trial under a transmission intensity that's too stringent to show a practical path towards malaria elimination. This is a false negative. If you take it into too high of a transmission area and your vaccine shows no difference between vaccine and control, you might have had a vaccine that you're going to discard that could show benefit in areas of what is known in malaria elimination as the end mile, low transmission areas, but you have to immunize hundreds of thousands of people to see an effect. There are important caveats. So what are your sample size calculations? You know, some things could be technically feasible, but they're operationally not feasible. And there's nothing worse than not, considering all the operational caveats and the problems that can occur. What is the lower 95% confidence interval of the vaccine effect? Andrew had in one of his slides a bullet I just wrote down. What is the efficacy required for a successful TBV? That's a simple statement, but it's very powerful. We do not know what the efficacy level needs to be for a successful TBV, because there's a lot of other components, including the existing malaria control interventions, new drugs, whether it's going to be administered with or without mass drug administration. So we have to there's a lot of work that needs to be done. Baseline study is required. So there's going to be, intercluster variation. Malaria incidence will change depending on seasonality of transmission, gametocyte reservoir, mosquito trapping. The cost is could be prohibitively expensive for funders in such a conventional pathway. And even if you do a CRT, it will not alleviate your responsibility of doing post-licensure follow-up studies. So this is a long path, and so we really want to get it right. Now, on the other hand, there's an accelerated approval, and we're not biased one way or another at NVI, but I think it's important to actually define how would you go about looking at an accelerated approval for a surrogate endpoint that's reasonably likely to predict clinical benefit. Well, there's an assumption, and the assumption I think most of us would agree is that an intervention such as a TBV that reduces the risk of transmitting the malaria parasite from mosquito to man will have a positive clinical benefit. But the real question is how much of that reduction do you need to have a positive clinical benefit? The biomarker must be biologically plausible. As you've heard in the preceding talks, we think we have the wherewithal. It's an antibody that acts inside the mosquito that will prevent the parasite from maturing ultimately into sporozoites and preventing sporozoite transmission. The biomarker lies in the causal pathway by which transmission of parasites from mosquito to man influence population-based incidence of malaria. This is the causal pathway. There is no other pathway. There's no cell-mediated immune mechanisms. And importantly, you're going to need a validated biomarker. And so as you heard previously, there's membrane feeding assays. It sounds simple, but you need reproducibility. You need all those elements of linearity, reproducibility, high sensitivity, specificity in order to get an analytically and biologically validated biomarker, which would be acceptable to regulatory agencies. So you've kind of seen this before, so let me just walk you through how one would do this. You immunize an individual with your transmission blocking vaccine, and there's 3 different scenarios that we have considered. You take these sera, you take immunoglobulin, you mix it with gametocytes in culture. These could be standard falciparum 3D7 or whatever you would like to. You do a standard membrane feeding assay, and you do standard membrane feeding, and you measure oocyst density. I have a question mark because, as you heard, that oocyst density may not be the right measure of what we want to do to determine outcome. So, but this is what we do. Now, I think we will refine our methodology. The other way you can do it is immunize individuals in the field, and you take their immunoglobulin and you take blood from them, and they're naturally infected with falciparum. They have gametocytes, and then you put it in a membrane feed. It's called a direct membrane feed, and you also measure oocyst density. This is a little bit more applicable to what's going on in the field as far as the oocyst density and different strains of malaria that occur. And finally, if you think about it, you can immunize individuals in the field directly, and instead of taking their blood, just feed mosquitoes directly on them and measure mosquito prevalence. So Toon and other before me have kind of gone through these different scenarios. So this could be a biologically validated biomarker. And we're working at all three of those type of assays with our partners at MVI. But unlike what I told you about a false negative, there's a possibility of a false positive here. And who bears the risk on a false positive? Well, on a false negative, like in the conventional pathway, it's the funder and the sponsor that bear all the risk. Here, the risk really falls on the regulatory authority. If they approve a biomarker and you are able to achieve zero transmission or greatly reduced transmission, it could be false positive. It could be because of an event like a seasonal event, low transmission, a introduction of new malaria control measures. And so you will still have to do a confirmatory trial. And such a trial to bridge between a direct feeding assay and malaria elimination, there are several different types of trials one could envision. At least maybe a challenge model, and that's what we're thinking of at MVI. And you heard just before myself, James talking about a challenge model, at least get the first hurdle about a direct feeding assay. Step wedge is a type of design that one could look at to confirm a biomarker in a post-licensure, and something like a before-after island type design. But this is not without its issues. And so there's several pros and cons that one could see here. I'm be more than willing to share these slides with anybody. But one here is that the pro for accelerated option would allow national health systems to be used for vaccination, and you use the malaria case management within malaria control programs to actually assess. It really reduces the complexity of of the type of trial. And there are several cons that are all also associated with an accelerated option. One of the most important cons is if you can't validate it and get it your assay validated in a way that's acceptable to regulatory agencies. So I'm going to finish up because I do think that there's important here, and it gets back to the question on this last slide, is what do you need to achieve as far as transmission blocking that you can predict will have a positive effect on reducing malaria transmission that will lead to elimination. And this is work that I think this is important work that's ongoing. It's not so much about this figure itself, but work that we're doing with a number of different partners at the Gates Foundation and also with Tom Churcher and his colleagues at Imperial College. And it has to do with what your transmission blocking, what's your season that you would want to do it. You're going to do it in a perennial or a seasonal type of malaria transmission. What's your coverage rate, all right? Because there are certain people that you're not going to immunize. You're not going to immunize probably pregnant, and you may not immunize young infants, and you're not going to immunize people who don't want the vaccine. And so you have to consider your coverage rate. You have to consider what is the level of efficacy that you predict from your phase 1 and phase 2 and the half-life. And what is your baseline incidence of infection? So the transmission and intensity, and and this is the protective efficacy over a span of 5 years. If you think about malaria control and elimination occurring yearly for about a 5-year span, how much efficacy do you need to be maintained? So there's a lot of work that needs to be done, and we think that we're on a good track with the candidates and the types of models that we're able to look at least in phase 1 and phase 2. Now, I'm doing this, and I just want to acknowledge 3 people, because David Kaslow from PATH has really spearheaded this initiative, malaria vaccine initiative, consulted with 3 large groups over the past year and a half, technical consulting groups. Many of you are in this audience today, and I thank you. Didier Lebelou is no longer with MVI, and him and Karen Ivinson, who's here, have really spearheaded the preparation of the reports surrounding the clinical and regulatory trial. So thank you very much.